thank you for inviting me to this conference, and I'm gonna talk about hepatocellular carcinoma medical approach. As we know that hepatocellular carcinoma, it is more in male than female, and it is the most common primary liver malignancy, and it is a hepatocellular carcinoma. It is the sixth most common cancer worldwide, and also it is the most second common cause of cancer-related deaths. So this is the risk factor for hepatocellular carcinoma, and as we know, the most common cause of hepatocellular carcinoma is hepatitis, related to the viral or either autoimmune or alcoholic-induced liver cirrhosis. So the 5-year cumulative incidence of hepatocellular carcinoma in patients with the cirrhosis, as we see that patient who has hepatitis C at 5-year cumulative incidence of hepatocellular carcinoma in Japan is 30%, while in Europe and US is 17%, hepatitis B 15%, and hereditary hemochromatosis 21%, alcohol cirrhosis 8%, and primary biliary cirrhosis is 4%. What about molecular pathogenesis of hepatocellular carcinoma? As we know that the histopathology for progression and molecular features of HCC, there is a viral, chronic lead to injury of the liver, lead to chronic liver disease, necrosis, proliferation. This necrosis proliferation lead to hepatocyte proliferation arrest, satellite cell activation, and this is the stage of liver cirrhosis. Liver cirrhosis, there is 2 stages. It is extensive, scarring, and abnormal liver nodule, and this abnormal liver nodule transferred to hyperplastic nodule, and moderate genomic instability lead to this plastic nodule. Another marked genomic instability, loss of P53, lead to hepatocellular carcinoma, and as we know, hepatocellular carcinoma classified to well-differentiated, moderate differentiated, and poorly differentiated. Diagnosis of hepatocellular carcinoma, we depend on radiology, and this is the ESL, non-invasive hepatocellular carcinoma diagnostic criteria. Now, as we know that the patient who has cirrhosis undergoes observation by ultrasound. If there is mass or nodule on ultrasound less than 1 centimeter, we go to repeat ultrasound at 4 months. And if there is any changes, so investigate. If it is still stable, we can observe. From the nodule that present on ultrasound 1 to 2 centimeter, MRI, enhanced MRI, or 4-phase CT should be done. And there is features, radiological hallmark for HCC. If there is 1 or 2 positive technique, it goes with HCC. And if we didn't find this, so we should do a biopsy to confirm this is HCC. More than 20 centimeter, 2 centimeter with 1 positive technique, HCC radiological hallmark. If it is present, this is mean HCC, and if not, we should do a biopsy. So the algorithm of a small nodule found on screening update guideline do not include CUS due to low specificity, and guideline apply to patients with cirrhosis or hepatitis B viral infection without full develop. So as I mentioned before, if it is less than 1 centimeter, repeat ultrasound within 1 to 3 months. If there is a changes, so investigate. If not, we can observe. So nodule less than 1 centimeter should be followed by ultrasound at interval 3 to 6 months. And if there has been no growth over a period of up to 7 years, so one can revert to routine surveillance. Staging is important in hepatocellular carcinoma, and as we know that the staging is used to determine prognosis and guided treatment. And staging of hepatocellular carcinoma is difficult because most of patients has underlying liver dysfunction, and key prognostic indicators are not clearly defined, and the prognostic indicator vary during the course of the disease. So guideline recommended that HCC staging system should consider tumor stage, liver function, and health status. And the importance of tumor staging, as we know, all solid tumor prognosis of solid tumor is generally dependent on tumor stage at the presentation. In HCC, prediction of prognosis is more complex as patient regarding underlying liver function tests also affect the prognosis. The tumor stage guides the clinical treatment decision, and the staging is very important so that the right therapy is chosen. And currently, there is no worldwide consensus on the use of any one staging system in HCC. So also it is important in a trial design. Staging is essential for comparing different therapeutic trial groups and the study, and most major trial of HCC therapy have chosen the BCLC staging system. So requirement for a good staging system is simple and easy to use, reproducible, and must provide reliable information on the nature history of the disease, and should allow classification of patient into different treatment group. And there is criteria or selected variables included in different staging system: tumor size, lesion number, vascular invasion, nodal involvement, distant metastasis, cirrhosis, child-Bach score, laboratory variable, and others like portal thrombosis, alpha-fetoprotein, and ascites. And this is a slide remind us about the child-Bach scoring system. And as I mentioned, it's a factor affecting staging system, tumor stage, liver function, and health status. So Barcelona Clinic Liver Cancer Staging System for HCC, it divides into stage 0, stage A to C, and the stage D. Stage 0, it is a very early stage, about one nodule less than 2 centimeters with a good performance score, and is candidate for transplant. If not candidate for transplant for other reasons, so some reasons, so it goes underlying ablation. Stage A to C is divided to early stage, intermediate, and advanced. So early stage A, it is 1 HCC or 3 nodules less than 3 centimeters with a good performance score. If there is 1 HCC with a normal portal pressure and normal bilirubin, we go to resection. And if there is a 3 nodules less than 3 centimeters, if there is associated disease, so no transplant, go to ablation. Intermediate stage, which is a more common stage, it is a multinodular with a good performance score, go to chemoembolization. Advanced stage, stage C, with a performance score 1 to 2, medical or systemic therapy. Stage D, it is end stage and only best supportive care. So as we see the stage 0 to stage A, the curative treatment is about 30%, and 5-year survival is 40 to 70% with the treatment. Intermediate, it goes with a palliative therapy from intermediate to advanced, and as the stage D is survival less than 3 months, while in intermediate to advanced palliative treatment, 50% median survival 11 to 20 months, while in early stage, the 5-year survival is 40 to 70%. So early stage SCC treatment, it is resection. What about recurrence after resection and current investigation for treatment after resection? And this is the guideline for resection, treatment choice for early HCC in non-cirrhotic patient. And non-cirrhotic patient tolerate resection with low morbidity. I'm gonna skip this for Dr. Khalifi will talk about it, but the indication for surgical resection for patient with single lesion, no cirrhosis, or patient with cirrhosis and well-preserved liver function, normal bilirubin, normal hepatic vein, pressure gradient more than 10%. And what about pre or post systemic therapy after resection? Till now is not recommended. And the survival after surgical resection, the 5-year survival, if the patient has absence of portal hypertension or hepatic vein gradient less than 10 millimeter HCC, so the 5-year survival is 74%. And if he has portal vein hypertension and serum bilirubin less than 1 milligram, so 5 years survival is 50%. Patient with portal vein hypertension and bilirubin more than 1 milligram per deciliter, the 5-year survival is 25%. And the recurrence after resection, it depends. There is a predictor for recurrence. And so the predictor, it depends on microvascular invasion, poorly differentiated, or multinodularity. So in summary, the surgical resection is indicated in patients with single lesion, no cirrhosis or cirrhosis with well-preserved liver function, normal bilirubin, normal hepatic vein. So phase 2-3 trial investigating adjuvant systemic therapy are underway. Although the STORM adjuvant trial showed has no benefit, sorafenib versus placebo after curative resection ablation, this study was phase 3 randomized study, double-blind, placebo-controlled study, study of sorafenib as adjuvant treatment for hepatocellular carcinoma after surgical resection or local ablation. The patient who underwent surgical resection or local ablation randomized to sorafenib versus placebo, but unfortunately, the endpoint, there was no significant improvement in RFS, TTR, and all-over survival with sorafenib, and the rate of discontinuation due to adverse effect was higher with sorafenib arm versus to placebo. So back to this slide, the surgical treatment in early hepatocellular carcinoma liver transplantation, I will skip it, and the guideline indication for transplantation effective for patients with SCC corresponding to Milan criteria, solitary tumor of 5 centimeter or up to 3 nodules of 3 centimeter. Living donor transplantation can be offered if waiting time is so long, so the risk of tumor progression is high, leading to exclusion from transplant list, and preoperative therapy can be considered if the waiting time exceeds 6 months. So local regional treatment of early hepatocellular carcinoma like percutaneous ablation, PEI and RFA and TACE, and the indication is in patient with intermediate stage, and the percutaneous ablation is the best treatment option for treatment with early stage, not suitable for resection or transplantation. And there is, I think Dr. Hilal will talk about the technique. I will mention that PEI is the best known and best studied percutaneous ablation approach. 90 to 100% necrosis rate achieved in hepatocellular carcinoma less than 2 centimeter, 70% between 2 to 3, 53 to 5, and well tolerated, and required repeated injection on separate day. So the efficacy, it is more PEI effective in a single lesion less than 2 centimeter, more than if the lesion is more than 2 centimeter. Radiofrequency ablation, we see in multi-study that the radiofrequency ablation in early HCC showed a complete response about 70 to 93% with a good survival 1 year up to 94%, 3 year up to 77%, 5 year up to 54%. So the meta-analysis of comparison of RCTS of RFA versus PEI for small, we see that the local recurrence, RFA has lower risk for local recurrence compared to PEI, and also the tumor response showed a better performance with respect to PEI in terms of complete necrosis. So compared with PEI to RFA, RFA is associated with more complete tumor necrosis, significantly improved overall survival, significant improved disease-free survival at 1 or 2, 3 years, significantly less local recurrence, and decrease in the number of treatment sessions and number of days in hospital with a comparable adverse event. Also, the RFA in combination with other therapies, this is a randomized controlled trial of RFA versus RFA plus PEI in early HCC. Also, the combination showed improved in overall survival in a tumor less than 2 centimeter, or in tumor with 3 to 5 centimeter. Transarterial chemoembolization in the treatment of HCC, and indication it is a treatment of intermediate stage. A relative contraindication, it is a tumor size more than 10 centimeter, comorbidity involving compromised organ like active cardiovascular disease, active lung disease, untreated varices at high risk of bleeding, bile duct occlusion, or incompetent papilla due to stent or surgery. Absolute contraindication for chemoembolization is decompensated cirrhosis, jaundice, clinical encephalopathy, refractory ascites, hepatorenal syndrome, and also extensive tumor with massive replacement of both entire lobe, severely reduced portal vein flow, and technical contraindication to hepatic intraarterial treatment and renal insufficiency. So the factors associated with positive survival outcome for the patient who underwent TACE is performance score 0, child bulk A, B, alpha fetoprotein less than 200, good liver function, male gender, and high pre-treatment albumin more than 35. This is associated with a positive survival outcome.
1 minute, please.
So I'll skip this for a period, but if the patient refractory to TACE, we go to other therapy, alternative surgery, ablation, systemic therapy, radio, and combination. And the HCC systemic treatment landscape has rapidly evolved since 2017. First-line therapy was approved sorafenib in 2007. And then second line, the TKI, other in regorafenib and nivolumab. March 2018, lenvatinib, other TKI approved. FDA and EMEA, August 2018, and in September 2020, combination of atezolizumab and bevacizumab was approved. And as we know that the pathogenesis of HCC involve multiple signal pathway in which tyrosine kinase play an important role. So the tyrosine kinase, several tyrosine kinase inhibitors are now approved for the treatment of HCC. First line, sorafenib, lenvatinib. Second line, regorafenib, cabazitaxel, and ramucirumab. And the overall survival in patients with HCC treated with TKI in phase 3 trial has increased over time. Patients اللي هن عندهم underwent TKI has longer over survival, especially with the sorafenib. And between the sorafenib and lenvatinib, there is a study, a reflect study, showed non-inferiority between sorafenib and lenvatinib. So both of them showed the same efficacy. This is the AASLD guideline 2019 recommend TKI for the first line of HCC based on high level of evidence. So level 1 resection, 0 if it is intermediate or stage C, sorafenib, TKI, and second line immunotherapy, and the third halater. Regorafenib, other, it is approved for the treatment of HCC following sorafenib, and showed that was the first second-line systemic agent to receive approval in patients with HCC who were previously treated with sorafenib. About immuno-oncology agent, nivolumab and pembro are FDA approved in the second-line setting, and this study, Nivo, checkmate 40, second-line good over response rate, and in the phase 3 trial, Nivo versus sorafenib showed that the median overall survival 16 versus 14. Pembro in the phase 3 trial, second line, pembro versus placebo showed at median overall survival 13.9 versus 10.6. 2IO combination strategy also have been approved for the treatment of HCC. So one more slide, bus. Atezolizumab plus bevacizumab is approved for the first-line treatment of patients with unresected HCC based on IMbrave 150 trial result, and we showed that the atezolizumab plus bevacizumab versus sorafenib showed overall survival 13.9, progression-free survival 6.8 months, versus 4.3 months. This is the guideline, NCC guideline according to based on high-level evidence. So the first line systemic therapy, still it is TKI. Second line, another TKI and immunotherapy. Thank you.